Good afternoon. Let's look at two tick-borne illnesses that are important for us to be able to recognize and discriminate and have a basic understanding of management and treatment. Again, I've set your lecture up to be in concert with your book. I've extracted priority information, not all the information, but enough for you to gain basic understanding and begin to treat. So the two tick-borne illnesses we are going to look at is Lyme disease and Rocky Mountain spotted fever. And I'm actually, the information is limited, so I'm going to discuss each one separately, but per slide. So let's talk about Lyme disease first. It's caused by a bacterium, Borrelia burgdorferi, or fori, and it's transmitted to humans by a tick bite. It's the most common vector-borne disease in the United States. From an epidemiologic standpoint, there's about 30,000 cases reported annually, but there is an estimated 3,000 cases that actually occur, so there's a real mismatch in cases reported versus what we're dealing with. The illness occurs after a tick bite in the summer, and a characteristic expanding lesion called erythema migrans may appear at the site of the bite. All stages of Lyme disease are usually curable with antibiotic therapy, but it's ideal to diagnose and treat in early infection. Now, Rocky Mountain spotted fever is much more serious and life-threatening febrile disease caused by Rickettsia rickettsii. It belongs to a spotted fever group as obligate intercellular bacteria. The tick is the host and the reservoir. Most cases, children are under 10 and adults are 40 to 64 years of age. It tends to be more common in white males, and it occurs most often between April and September. Pathogenesis of Lyme's disease, it was recognized in 1976 from a cluster of children from Lyme, Connecticut, hence the name Lyme disease. The vector of transmission for Lyme is the Ioxidis tick species. And horizontal transmission with the bacteria from ticks to human usually occurs after 36 to 72 hours of attachment. Clinical presentation of Lyme disease, localized infection, there's that pink-red spherical rash at the tick bite site. It's called, again, erythema migrans. About 70 to 80% of the time you see that rash. 3 to 30 days. Patients also report burning, itching, and pain at the site of the bite. Early disseminated infection, there's usually multiple annular lesions, malaise, fatigue, headache, fever, chills, achiness, and regional lymphadenopathy. Untreated, about 15% of these patients will go on to have neurological symptoms, and they might present with Bell's palsy, meningitis, or encephalitis. Late persistent infection, which is months after infection manifest, is in intermittent attacks of large joint swelling. So if you see a patient come in with large joint swelling intermittently, you need to have in your differential a tick bite Lyme disease. And fortunately, the natural history is complete resolution of symptoms and disease. There are variants, but that's the majority of people. The pathogenesis of Rocky Mountain spotted fever is that the rickettsia are transmitted to humans through a tick bite. The ticks must be attached about 6 to 20 hours for transmission to occur. It's not only been reported in labs that inhalation has been spread through into the pulmonary and vascular endothelium, but even removing ticks and that squeeze between the finger and not doing it correctly there has been some transmission with that. From clinical presentation standpoint, Rocky Mountain spotted fever incubation period is 2 to 14 days. Classic triad of symptoms and signs, there's severe headache, fever, and a rash. About 60 to 70% of patients have this classic triad. The rash is present in about 88 to 90%, and it's a major diagnostic sign. The rash will begin in 3 to 5 days and first presents at the wrist and ankles. There are small blanching erythematous macules that evolve first week into a macular papular with central petechiae. Symptoms can include myalgia, anorexia, nausea, vomiting, abdominal pain, and photophobia. Unfortunately, signs of meningitis and meningoencephalitis are indicators of poor prognosis. Death usually occurs between day 7 and 15 from onset of symptoms. If untreated, fulminant Rocky Mountain spotted fever death occurs in 5 days. In certain populations, one happens to be in black males with a glucose 6 phosphate deficiency, and this blood disorder just really accelerates hemorrhaging. So the physical exam of Lyme and Rocky Mountain spotted fever, I want you to refer back to the clinical presentation because those are the things that we would be looking at. Certainly, both require a comprehensive head to toe for these patients. This is not a focused exam. This is comprehensive. And I included a picture of the rashes on both on this slide for you to look at. The erythema migrans, and then that macular petechial type of rash of Rocky Mountain spotted fever. And again, descriptive of the name, the rash. Diagnostically, Lyme disease, CDC recommends a two-test approach for screening antibodies, and the serum is screened by ELISA and WB. Rocky Mountain spotted fever is almost always based on clinical findings and epidemiologic data that you collected. But isolation of the rickettsia in the blood is ideal, but it takes time, and you do not delay with Rocky Mountain spotted fever. You have to move forward into management and treatment. Lyme's disease management, the treatment guidelines do vary by stage and neurological involvement. I want you to go back into your text and look at that. As primary care providers, we have to be knowledgeable of how to treat early and, Lyme's disease early or disseminated, and also the lab that needs to be ordered. And we know that typical treatment involves doxycycline 100 milligrams twice a day for 14 days. Pregnant women and children, we can prescribe amoxicillin. Disseminated Lyme disease generally requires 2 to 4 weeks IV of ceftriaxone. As far as Rocky Mountain spotted fever, the management, again, I cannot reiterate enough. Decision to treat should not be delayed. Early initiation of therapy is critical for a favorable prognosis. So we do use doxycycline for 7 days or 2 to 3 days past the resolution of rash, so it can be longer than 7 days. And chloramphenicol is the treatment of choice for pregnant women. So referrals. Both Lyme's and Rocky Mountain spotted fever may require an infectious disease specialist, especially the Rocky Mountain spotted fever, but Lyme too. Just depends on, for the Lyme disease, the patient's symptoms and severity. And then Rocky Mountain spotted fever, since you've been told and you read that the decision to treat should not be delayed, early initiation of therapy is critical for a favorable prognosis. You're anticipating hospitalization for these patients and close assessment. As far as patient education and health promotion, it's important for us in both instances, Lyme and Rocky Mountain spotted fever, to teach our patients how to avoid tick bites, and using DEET and long clothing, and then checking their skin after. Also removing ticks as soon as and doing tick checks after they've been outdoors. Thank goodness for Lyme disease, we can offer antimicrobial prophylaxis as appropriate. That's usually doxycycline. But we have to remember to assess for tick-borne disease symptoms up to 30 days, and you bring those patients back. As far as Rocky Mountain spotted fever, unfortunately, antimicrobial prophylaxis is not indicated, and so treatment would be initiated at as early as possible. Thank you for your attention.